whenua he whakaro pai ki ngā tāngata katoa āmine. Anei mātou I tuku mihi ki a koe, anaki tia mai ki a mātou I roto I tā mātou nei mahi I tēnei rā. Anaki tia hoki I tahi I te roto I tēnei hohi pere, kia piki tā rātou ora. Amen.
Amen.
Morena and morena to those who are joining us on our live feed today. Thank you once again. Welcome, Josh. Good to see you, and hope that you are feeling better soon. So we'll kick off. We've got reasonably quite a lot to get through today, and there's another meeting on this afternoon, so we will have to keep our agenda moving. So firstly, we have apologies today from Meredith and from Amy. Josh is on Zoom with us, and we are anticipating that Na will be coming in person. I think it's all of our apologies. So we've got no one presenting this today, Jim?
No.
No. So we'll move on to register of interests, which is page 4. Any updates, if they can just be sent through to Nikki and Rachel. At 2.2, does anyone have any conflicts in relation to any agenda items? Item 3.1, our previous minutes from 27th of April at page 8. I just had one matter on those minutes at paragraph 7.2 on page 11. I think we weren't referring to the list of actual patients, and it's not what's reflected in Mill's report. Are there any other corrections? Oh, yeah, no. Any other questions or corrections? Okay, so we can note those as approved. Any matters arising? Carl? Action items at page 14. Jim, can I pass those to you, please?
Closing our doors.
Just noisy. Oh, sorry. Okay, so that incident review is in the in-committee part of the agenda. The Consumer Council, we've got those 2 items isn't on there. The alcohol-related ED presentations, we're still doing some work around what's happening elsewhere in the country about that. The tracer information.
So I'm still trying to find the right person for this. I just wanted to check in. This was in relation to R&V and the amount of local people that, the amount of people that used the app. And I'm wondering, does the committee still wish to receive this information?
I think the committee was more, the board was more interested generally in whether or not there's regional level information on app usage rather than specific to R&V.
Okay,
so came up within the context of R&V.
Okay, so that was very specific I was looking for in terms of that. And I noticed yesterday, just FYI, in using my COVID app, there's also information that sits in your COVID app that tells you the number of utilisations countrywide that you can actually find. So
I think it was quite Tairāwhiti specific that we were keen.
I will still keep exploring the option to find out how we can identify regional utilisation.
So there is a link to a spreadsheet on the Ministry of Health website, but when I opened that up, it was just, I just couldn't interpret it.
Yeah. Well, it's very difficult trying to find the right person to provide us with that information. I'm going to try and track our vaccination IT person to see if they can put me in touch with the right people, because there's such a significant turnover in the Ministry of Health of people.
Okay.
Morning, everyone. Excuse me. Start on in here and disrupt the whole place.
The code of conduct, that
The late attendance.
Yes. Yeah, quite a bit of work involved in just checking through to make sure our code of conduct aligns with the Public Service Commission's suggested document. The RL surgical list is a paper on that in there, and the over 75 readmissions. So yes, we were doing a bit of doubling up on that. So you'll see the reporting has improved, the outlook on that has improved. Now we've checked to make sure we're not double counting in people inappropriately in that.
Good point. Anyone got any questions on action items? Then we've got no correspondence in this session. It's dashboard at page 15.
Yes, so still that we were making a little bit of progress about improving around immunisation, but that hasn't carried on this month. But I don't necessarily have any comments on that in terms of meeting this afternoon with primary care, so we can again.
So primary care have said to us, so we're trying to find out whether there's something again around their coding and their reporting system, but they've continued to say to us from the beginning of the COVID vaccination, they're going to focus on improvements around MMR. So my expectation on the feedback that we've had is that it should be up. We are aware though last year when we had a drive on that it took quite some time for those numbers to show through on our local information. So we have checked back through, just waiting for an update from the HO on whether there's been a glitch in information.
So what can we do to help bring this up, these childhood IMS?
I thought childhood IMS was on the up.
But it hasn't got. It was, but this last month it's gone back slightly. Yeah. Well, for the total population, it's gone up, but for Māori, it's dropped back.
It is an area that has been identified as the same across Manawataki. It has become an area of focus for Manawataki. We think that the environment that mums are exposed to when they want it, when the first immunisation is due, is needs a little bit more in-depth understanding, so that the option to have the immunisation for baby is prioritised. We know that across the region we catch up at 2 years. We've said that in an ongoing way. It's the early immunisations that we are not hitting. And so
even at 2 years, we're only at 81% for Māori. Target about 95. So
that was looking better than that as well too, but I'm thinking that that's now starting to flow through. You're starting to get the dip that occurred with COVID starting to come through on that as well.
It's also that we've had there's been less anti-vax activity in the environment. There is a dip that went on for a period of about 9 months where the anti-vax campaign actually showed directly into the loss of immunisations at that point. So it is a focus of this year's regional equity plan, and the alignment to local immunisation steering group to a regional immunisation steering group is being mooted as a collective to receive the information and collectively work on how we are going to respond at a deeper level.
Is there any data that shows any reason? Is it about accessibility? Is it about if we took the service to the homes that might improve?
I think the outreach immunisation is the only group that deliver outreach services. Everyone else is expected to go to their general practice. It may be one of the solutions that's brought forward as a result of having a connected and focused approach in dealing with the issues that we across Manawataki are. Every single DHB is mirroring the same data.
The and Wild Child Tamariki Order Services, well, our iwi provider, Wild Child
Been
Tamariki Services,
boosted.
will also arrange for people to get to their immunisation. So that's another thing that we're doing to try and enable people to get there.
The fact that it's low across the region would suggest to me that the business as usual approach is not working in this environment.
Yeah.
And that we're going to make any inroads, we've actually got to change it.
Yeah. So the business as usual approach is you get contacted from your general practice and you get an invitation to come and get immunised. That is the business as usual process, but that's not what we're doing. We've got outreach immunisations, so we've got a team of people that go actually out and visit people, and we've got our iwi health providers specifically working to enable people to get in. So yeah, we're not using business as usual. We've got a number of different ways in which we're approaching it.
So the data feeding back from those two formats to me would be critical to understand whether mums or parents are engaging at that level in the home. Are they actually declining to have it while the service is available, or are they then partaking?
Used to be they would get delayed uptake, but that doesn't count if you get a delayed uptake.
Once you get an uptake.
Yeah.
It doesn't count at the ministry and where we get our information back from, our data coming off the National Immunisation Register. If you miss your 8 weeks, it doesn't count.
Even if you get it at 9 weeks, it does right now.
Or is the conspiracy theories that are abounding having a greater effect than we think?
But I think there's been a higher profile of the conspiracists in the last 4 years, particularly. But in terms of immunisation, that kind of barrage slowed up before we had COVID, and we were starting to get some traction back. I do believe, though, that care for mum at that time in her life and the baby's life is about making sure that that immunisation is absolutely accessible for the child, and it may be a change in model is needed. We've got a pilot for Wild Child Tamariki Order about to go live in July that will have a higher focus on those mums who may need increased care and support, and will be part of their program of work. The other thing that's on track and coming on board is the opportunity to expand workforce in that space with Māori providers, which they're very eager to see in terms of immunisation, driven by COVID, in terms of more options available.
So that's for Māori 81% at 8 months. So ideally we're getting people vaccinated, vaccinated by that 8 months. But that doesn't mean that the 9-month-olds aren't vaccinated.
No.
So do we have that next layer of data, that's the 8 weeks plus the delayed uptakes, so that we can get a picture of like, of the 100 people, there's actually 97 of them who are vaccinated, even if they're a week or two late.
We can ask so the NIR should tell us that information, so we could ask the NIR team.
Now that's a good point, because I took my mokopuna and she was 2.5. So is that delay, is that what's causing the drop in the number, the lower number, the data?
Yes.
But is it the date?
Now it still won't count as
Yeah, you're right.
I think that's what I really want to know.
There's actually also five.
Babies, how many
You've also got 5-year-old data. Data at 5 years as well.
The rod on our back at the moment is the way in which we're counting.
And that's the point in time that is
It's
clinically
due
for them to be done.
Yeah.
But it would be really good to know
We could have a look
the
and see
actual immunisation
whether
status.
that information can be drawn in that way.
Are there any other parts of this that you wanted particularly to draw attention to, Jim?
Yes, another one that we need to talk to this afternoon around is advice about quitting smoking in primary care, which is low. I think that is a factor of the most access to primary care at the moment is by telephone conversation in the first instance, and that may miss the opportunity to have that conversation at the same time. So we just need to check to see whether that is being offered.
It was good to see the sort of continuing trend with lower paediatric admissions in ASH.
Yes, and also the ash 45 to 64 ash for Māori is actually, while we haven't achieved the target, that was a very ambitious target, I have to say. We have actually seen that reduction this year compared to last. So that's.
Does anyone have any particular questions on the performance dashboard?
The only other one I'd just like to highlight is in that diagnostic waiting times, clean sweep there of all of those better than target. So
Well done.
Nice.
great work by those across the radiology and our colonoscopy service.
Just a query on the bottom of page 15 about PHO enrolments and looking at 10% of Māori are not enrolled anywhere. Which, is that right across the whole region? If you've got 90% of Māori enrolled at a PHO, means that 10% of our Māori population are not enrolled anywhere.
So those percentages are based around estimated populations. So that's based on the census.
And the census was a bit flawed
So,
this time round.
certainly, I know that in the COVID vax work that you're doing, you're looking at how we are ensuring we are finding every single person within Tairāwhiti to make sure they're vaccinated, and that would be similar around ensuring that they're enrolled in the PHO as well. With a practice really is what they're enrolled with.
Okay.
It's actually 10% of
We'll move on to
yeah,
So be
10%
careful,
of 2%. Oh,
the whole population.
okay, move on to item 6.2, which is my report. So this month is it's been quite busy with mostly conversations around the reforms. It's been a fairly standard set of meetings. So we're back to meeting weekly with the Minister. It's just a fairly general touch base, and the consistent issues that are coming up. There's a discussion on the vaccination program, financial sustainability, and the reforms. That's the most consistent set of things that the Minister raises with chairs every week. At Te Manawa-Taki, we met again this month, the chairs, and again that was a fairly general update discussion on really what a regional view of what we can do as a region during this transition period towards the reforms. We are working, so although the regional divisions aren't yet confirmed, we are working as if Te Manawa-Taki will be a regional division, and we'll just continue to do that until we hear otherwise. Chairs met in Wellington and had sessions with Ministers Little and Hipkins, and further progressed the discussion on the reforms. And we also had quite a discussion on whole of system support for stronger advocacy for policies designed to address obesity. So all of the chairs came in supportive of that and of public health taking quite a strong lead in that. One thing that we will start providing to the board as soon as, I think there might be still a couple of data glitches in it that just need ironing out. But Te Manawa-Taki's instituted regional level reporting on the vaccination program across the 5 DHBs, and it's got quite a good layer of detail across the 5 DHBs. So we'll bring that through and get that forwarded out to the board. Like we're certain that all of the data collection in that is right. So that's been managed by Health Share, which is our shared service agency.
Is it far up?
Sorry?
Is it far up? Is it?
No, I don't think so. Are we almost there?
I would think so. Yeah.
I'll just double check that the last
The
one.
report, the VAX report that Anna Lyburn produces.
but yeah, well, once that comes out, then we can provide it to the board.
I have a sense it's going to be quite good media fodder in the coming months.
Yeah, so the media is very attentive to the vaccination program and can actually be, an enormous help to us, really, on many fronts. And spreading good and accurate information, but also, as it comes with the media, shining a spotlight we can do better, and it'll be important for keeping us working to plan. Okay. Hand over to you or to
First of all, Heather, we haven't touched on that spot around the cultural courts you were talking about, so apologies for that. We will obviously come to that next week with Tormai and I are going to work on those particular bits. So that was Heather asking for some cultural measurements, so I call them those, work process.
Yeah, equity, culture and treaty considerations.
I guess.
Yeah, so we'll work on that. Uppermost has been the reforms, obviously, and how the iwi fit into those reforms. In particular, you'll recall we were going through a reorg of the Te Waiora Nukutai Memeha terms of reference, so that it became an iwi reference board rather than just a pan Māori board. So there was that discussion from the Toitu, wanting to be involved in that. That was pre the announcements, the minister's announcement. So this is now given it more focus, I think is probably the best way to explain that.
So the strength and role of partnership boards in the reforms, we probably might want to dig into decisions that have been taken thus far on that.
Yeah, it's difficult to see where they're going to play. So whether or not they're at the lower tier level around localities, or whether in the regional space, probably as high as they will ever go, I think. I don't know if they'll go as high as the actual MHA, the HNZ space. I'm not sure if MRBs will play in that area. But certainly that's the difficult part of finding out where MRBs, because in the structure, if I understand it correctly, with the 3 streams coming down, the difficulty will be about where the MRBs position themselves across their whole lateral structure. There's kind of no indication at this stage how that might play out, unless there's been a meeting yesterday and there's an update.
No,
Nothing.
there's still a fair bit of policy work to go on down in Wellington to get to the point of legislation being ready, and I think there'll be, that whole side of the equation is still subject to quite a lot of design work.
My take on it is they're waiting for iwi to tell them where they want to be positioned. That's my take on it. Doesn't seem to be a lot of information coming out of Central.
Does the Crown not have a view? Do the ministers have a view on what the articulation of a treaty relationship is?
So have you all seen like the cabinet decisions and the comms material?
No.
I've seen that around. It's all available on the Transition Unit website. So there's a really large body of information. The ministers do. They're really committed to the reforms being consistent with treaty partnership. Part of that is reflected through their agreement to establish a Māori Health Authority. They're very committed to Health New Zealand also continuing to be responsible for Māori health, and to a lot of local level decision making through the commissioning activities and the strength and role of the partnership. So yes.
Yeah, they certainly have a view. It's just not clear how that translates into localities.
And I think that's because the high level decisions have been taken rather than the design.
Yeah, and I think a really key one around that is the fact that the Māori Health Authority will not be a Crown agency.
Yes.
As an example of the high level thinking is there. So it's not a Crown agency, but what is it?
and it will be accountable to both Māori and Māori. So that's one of the design features that has to be worked into it, is how it is accountable to Māori.
So we aspire regionally and locally to be a reflection of that relationship. Is that effectively what we're looking at? Yeah.
So my question listening to you was, so if we're not waiting for the Crown to say what they want, well, in the meantime, let's work out what we want.
Exactly right.
When that's not wait for that, and across the region.
Exactly.
Your comrades saying.
Well, we don't know what the region looks like because there's been no definition.
The region is the standard moment.
Yeah.
Do you know what iwi looks like?
Yes, we absolutely do. And so
That's the that is the consultation that's going on at present.
yeah, so we've also committed as Te Wairua Nukutai Memeha to hold a wānanga day with iwi around the terms of reference in this discussion will form part of that information flow back to iwi around what we think it looks like or could look like, and basically get iwi to make some forthright decisions about where they want to play.
Good.
And that will really start to get momentum once so in the first instance, interim agencies are going to be established. And so there'll be an interim Māori Health Agency from September. And I think that's when the design work will really start to get some, momentum of how this is actually going to play out in practice. Okay. Is that you? All right. Jim, we'll pass over to you for your monthly report, page 17.
Yeah. I just included there at the start that tiny reminder from Osmansaw, 225 years of vaccines in the world. So not a new concept, and certainly a lot of work and development that's gone over the years, and with our latest developments around mRNA vaccines. And the success that's been seen in the utilisation of those in terms of this current pandemic with COVID-19. So a timely reminder for us all about that. Financially, last month was we had a positive variance to budget last month. There was quite a large amount of additional funding that had come through to the provider from the funder that was recognised in the month that assisted with that, and that same pattern underneath that of expenditure in relationship to some of the costs around COVID-19, but mainly around our work to provide the coverage of services within the community and in the hospital, and particularly around the catch up on additional on elective work, including the additional electives. And on page 18 there's a little bit of a summary there around the result and some of the areas, the key areas that are affecting that. And we're confident now around receiving that additional elective revenue of $827,000 year to date. Analysis there, but other areas such as that quite substantial increase in leave liability that we've experienced this year as our staff are less inclined to take annual leave in the current environment, and also our staff who've got entitlements around education leave not taking that due to the lack of opportunities to do that at present. So that's building up quite a head of steam there in terms of untaken leave liability, and that's a feature across DHBs across the country.
Is there anything we can do about that? Like at a management level? I mean, it's been a year now. Sorry?
Open. 665.
Bubble. And the Tasman bubble is already starting to have a little bit of an effect there. I know that,
we don't
opportunities that
overseas markets available for the organisation to have a structured plan around taking leave.
We just have to roll out the program to actually state that it's going to be a requirement.
Yeah.
I'll do the individual employment agreements allow for.
Well, it's the unionised.
So so in terms of some MECAs there's an entitlement there, not just leave, but, for instance, continuing medical education leave that accumulates. And unless it gets taken, it sits.
What are the general arrangements around annual leave, that annual leave liability and the organisation's ability to manage their, mental health, well-being, and our leave liabilities in terms of a discussion with employees about taking leave to manage our liabilities and finances and their well-being.
Yeah, so we actively manage leave for people, but at the moment what we're seeing is, there are people we've got a policy around 2 years entitlement, and so we monitor particularly those people with over 2 years entitlement. That's around about 50 people out of our staff of 1,000.
Sorry, what's 2 years entitlement now?
That people can accumulate up to 2 years of leave entitlement. Yeah. And then, but obviously we work before that to try and make sure we don't get to that point, but particularly for those people. So we are working with people, trying to encourage them to take it. But a number of our people have plans around what they want to do with their leave.
Sure, we also have, an organisation to run and liabilities to manage.
Jim, if the policy is it a policy or contractual based reflection that the 2 years you use it for 2 years? Because if it's a contractual obligation or contractual,
it's policy based. It's not contractual.
All right, so you can't say use it or lose it.
No.
But you can consider the policy in the light of the current environment too, and have a conversation about that as to whether it's still the right balance of things.
It's fit for purpose.
And, other factors like for continuing medical education, it was a 3-year time period to use that one. That was extended to 5 years at the start of the COVID time. I guess on the view that, the world will come right and we'll be able to take it. But to date, the world hasn't come right. So people haven't been able to take it, but they've got a 5-year entitlement now.
So
to accumulate that.
Ask the professional leads with deferring continuing medical education. How are all our professionals, maintaining their requirements through their vocational colleges and their regulatory authority requirements?
So from a medical perspective, the Medical Council decided last year that there wasn't a requirement for a CPD, so they gave them an extension until February, so there's no requirement.
But there is now.
But now from February onwards, there is. It doesn't necessarily require them to go overseas. The requirements are to accumulate, so for medical staff is to accumulate 50 points, of which 10 points are audit, and there's probably about 20 points for other activities, so they can do online stuff. So the need for them to go overseas is no longer there to get that. So if they go overseas, they usually tend to take, say, 2 weeks for the conference and then another 2 or 3 weeks for annual leave, which means that exhaust that. So most of the SMOs have between 8 to 10 weeks of annual leave, which is quite a significant amount. The ASIPS agreement provides you, so after you cannot enforce leave until 2-year mark. At the 2-year mark, if you've got excessive leave, then you can. There is the note in the MECA that says you have to have a discussion with your manager, and then the leave you can be asked or forced to take leave. But until that 2-year thing, there isn't. It is up to the responsibility of the head of the department and the clinician or the annual appraisal to have a discussion. You need to have this, and this is your plan. This is your plan for CME. This is your plan for your annual leave, and ensure that at the next appraisal that is actually that's actually happened.
How many are at the 2-year mark, and how many conversations about enforcing leave have we had?
I don't know.
I can give you the numbers. I haven't got them on me. But a number of people that are
Question that would
in that.
So, it's not really about that. It's about a more managed process than that. But I guess it's instructive to what the lay of the land looks like.
So in terms of that, if I just use the leave thingy, what happens in July 2022?
Everyone,
Including the MECA?
All the assets and liabilities transferred to the
and
new
the current
organisation.
terms and conditions.
I just recall reading in the Minister's letter of expectation that all of these things will be managed down, should I say, or ensuring that there's a tight lid on that going forward. So in other words, not building it up and just let it go into HNZ. So there is some expectation there on Minister's letter.
I think as a board and a management, the obligation is on us to manage that as best we can at all times. You know, it's as much about people's leave and mental well-being as our liability, and it shouldn't be about transferring something to HNZ in the right form. It's about what we should be doing as a board with the management team now to get that balance right.
It's quite different for us as well because historically our leave liability is compared quite well with other DHBs, and in fact every DHB is seeing the same effect. So we have done well in the past,
but the world is different and will be for some time. So we need to consider whether our policy and approaches are still fit for purpose. I would think, particularly as we see this only going one way.
Is there some capacity issues as well? I know quite often staff are on leave and they get called back because of desperation, really, that positions need to be filled. I know that happens with nursing quite a bit, where not so much on annual leave situation, but a weekend or something like that, they're called in because the nursing managers just can't find anyone else. So is that having an impact on those figures as well?
Not a significant impact on this.
And not if they're not being called back and off leave. Like if they're getting called in for an unexpected weekend, that wouldn't have had any effect on leave entitlement.
No.
But it keeps adding on though.
Adding on?
Well, the leave availability, because if someone's taking just small amounts of leave, a day off here and there, they can quite often get called back in. So that leave doesn't then come off their leave entitlement.
Yeah, sure. If they were to be on leave and then they're not. Yeah.
So I guess the overall tone we're hearing is the board is keen to get briefed on the sort of ongoing management arrangement around leave management, and keen to see how we can ensure that our staff are actually taking leave that they're entitled to.
It'd be interesting to see if that 1.264, how much is sitting on that two-year plus cusp, and as Anila said, is actually able to be.
So that's the increase this year due to COVID.
Oh, that's just the increase.
Not the total leave.
Oh, right.
Total leave liability.
Where was the total leave liability? There's so much.
In the balance
sheet.
Okay, moving on. So just in terms of throughput for the month, it was down a little bit, so that was good. And I just got the usual graphs in there, which I won't go into great detail about again, but just to highlight that I did take another look at some of those ones around the emergency department in terms of arrival and numbers of admissions, and just cut you out there the last period of time from that, because it seemed to me that in that graph in the middle of page 22 around the number of admissions that result out of the emergency department, there was an upward trend of flattening off and then possibly a reduction in the last 2 to 3 years. And in fact, that is the case. If you look at the top of page 23, if you take just that period of time there, and of course, disregarding the plummet there in March, April last year, that there has been a reduced trend of people being admitted, having attended the emergency department. Whereas at the same time, there is still that increasing trend of people attending the emergency department. So two things about that. One is that, that I think is reflective of access to primary care, the increasing numbers of people coming through there, but also with the admissions from the emergency department, that the team there are doing a great job in being able to work with those people coming through there to come up with solutions and things for them, so they don't need to be admitted to the hospital. So that is a good trend that is happening there.
So what do we know about the sort of demand supply gap with primary care?
I think it's two things. One, it's a little bit about demand supply gap, but I think it is about their mode of operating now, with the need to phone first and have a conversation. And while that is a good thing because it provides options for people, I think sometimes that, and particularly for our population, trying to access services out of hours on the weekends is, people prefer to come to the emergency department.
At least if they're sitting in the queue, they know that they're going to be seen sometime before a prescribed time.
And, we consistently meet ED6 target. So, people are getting through there.
So the telehealth isn't really getting through the patient consults at this point.
In primary care, or it is. So those people that get into that system are getting seen. They're getting personal experience. They're getting a prompt call back from their general practice, and a plan made. And then on page 24, and also important around two things. I mean, A, about our costs within the organisation, and B, our requirements around planned care, is seeing that big rebound in the amount of planned care that is happening within the DHB this year, both in terms of numbers of cases through and the case weights involved in that. So that's another reason why we're confident about that additional revenue that we'll be receiving for that work. And so just maybe before I get onto that bit further, just to talk about the strike by members of New Zealand Nurses Organisation, which we received notice for the 9th of June. We've got Sarita here, who's our lead contingency planner for us over that period of time. An update on what I've put in there is that Sarita, after developing up our LPS life preserving services plan with the team last week, was able to work through that with our NZNO colleagues and staff members last Friday. A long day, but got through there in the end and was able to sign a LPS agreement for the coming strike notice action on the 9th of June. That's an 8-hour strike between 11 o'clock in the morning and 7 o'clock in the evening. So that straddles two shifts. NZNO members come to work in the morning, work for 4 hours, some of them 3 hours for others, and then leave. And then the afternoon shift will start late at 7 o'clock in the evening. So yes, our LPS agreement is in place. We have got a number of nurses who are not NZNO members that will assist with providing cover. We've got a number of volunteers who will help. We'll be looking to talk much closer to the time. We'll be looking to ask families who may want to come and support their family member in hospital over that period of time as well.
And how close to the proposed strike action do we have to be contacting people to defer planned services?
From about the Friday before, so it is actually the Wednesday after the Queen's birthday weekend. So so we would be so normally about 5 days out we would start to ramp down elective planned care, and so it fits reasonably well with that period of time anyway. And yeah, so we will have stopped in inpatient planned care on the Friday, and then and gradually reduce the load on the hospital over that period of time. We're not sure what that will look like. It's winter, so we're not sure what that will look like on a particular day as to how many wards we will have open at that time, but it would be our preference to try and contract down as much as possible and be managing the care of people, inpatients, in one place if possible at that time. Meanwhile, there was mediation with NZNO last week, which was unsuccessful in coming up with a solution, but there's still further work talks going on since that period of time. So we're also hopeful that we will be able to get an agreement with the union and its members and avert the strike action.
And if, for example, we have already started kind of reducing the hospital load, and then the strike action is averted. Does it take long to quickly wind back up again?
No.
It's just a matter of rebooking people.
Yeah.
Okay. Good.
And then planned care production. A couple of points just to talk about in there. Just a note in there around the trajectory compliance. So the Ministry of Health is changing the way in which we'll be monitored around our planned care performance from, they've started looking at doing it that way, but they're definitely going to be doing it that way from next year in terms of monitoring performance and the funding attached to that. So the trajectory is really, before it was more around, have you done this? How many of this have you done? How many of that have you done? Now it's really about looking at the trajectory in terms of how you are progressing, measured quarterly towards the target of getting back to be SB compliant at SB2 and SB5. So SB2 is for business assessments, SB5 is for treatment, and and that trajectory there. So bearing that in mind in relationship to where we are currently, you can see that we are we have got a good trajectory going on at the moment. Our first specialist assessments, people waiting longer than 4 months for our first specialist assessments, has dropped quite a significant amount in the last month, and that is as those pieces of work that we've been doing have started to kick in, and particularly looking around those areas that we are focusing in on, ENT, ophthalmology and urology. And so the numbers of people waiting in those areas have dropped back, and also in relationship to treatment as well. And we have dropped that back from a peak what's a peak of 112 people waiting on 4 months for treatment back in February to 129 in April, and down to 88 by the end of the month. So I think it's a really, really good piece of work that our clinical teams and those supporting them have done to be able to do that. And we must, say that we've been getting support from Lakes DHB around ENT and people coming from there. And also we're going to get some support around ophthalmology services from a private provider there and others that are helping to do that. So it's certainly a lot of effort being put in across the team to make those kinds of gains that we're making.
That's great. That's good.
I think that's about the main areas that I would highlight in that report. But if people got questions.
Anything from you, Josh? Carl? Has anyone got any questions of Jim? Yeah, I've got questions on the financial report, but we might hear from Craig first and then follow on those. So financial report is at page 35. Over to you.
Okay, good. Thank you, Madam Chair.
Jim? Thank you.
Yep, so you're just following on from Jim's update on the financials. Take the paper as read. We've got the consolidated P&L on page 36. We've got each of the three arms of the DHB, page 37 through to 38. Balance sheet, page 39. So if we can see Kim referred to earlier on the employer entitlements. We've got 15 million there. So not too bad compared to, pretty bad to where we're looking at year-end budget, 11, but tracking against year-end 30 June 2020. We're not too bad, but there's quite a few different things that sort of make up the leave entitlements. So we've got sabbatical leave, long service leave, retiring gratuities, payroll, ACC, KiwiSaver. So there's quite a bit in there. Capital expenditure on page 40, that's tracking well. You can see the total report approved and carried forward in prior years. We're tracking down towards zero. We've got a negative variance here of 128k, but that's we expect it to be zero by 30 June. That's holding up well. 6.579 million in the bank. Still got a 1.1 million outstanding from the ministry. reimbursements of our capital expenditure from the 3 million for the deferred capital spend in Morrison demolition. We've got works progressing at the end of this year. Radiology refurbishment, stage 1, stage 2's almost complete. It's around 325 K in there, and a few other bit of capital items, work in the steam pipes and medical air. Forecast has improved from prior month. We're now looking at a 2.6 million adverse to budget. The big upswings there came through in additional funding for COVID and some reclassification of expenditure in COVID, really seeing all the accruals. Their year was up around 300,000 on forecast.
So that was where my questions were around forecasts, as they tend to be at this time of year. So how confident are we there in the reforecast?
As confident as one could be with wash-up store to come in. So Farmac under expenditure, that's still washing through, that changes period to period. We've got the IDS wash-ups that will come through, but based on what we know, reasonably comfortable with that figure.
Okay. The other question I had in the forecast was about provider payments. So we're currently 5 million over budget year to date in provider payments, but we've still got $12 million yet to pay out. And the forecast is us overspending by 6 million. So how does that all work? Like, how come we have we planned to overspend $6 million on provider payments?
Provider payments.
Where are you?
So I'm on the
41.
forecast.
On page
Page
41.
41,
Yep.
total other providers. So our budget, our plan, which I had thought would have been, on the basis of contracts that we're entering into, is for 100 million. But we're but we're forecasting to be spending nearly 107 million.
Yeah. So there's a number of things in there that are additional revenue areas. So there's the COVID testing that was not budgeted, and then there is the additional expenditure on Farmac that obviously we didn't budget because that wasn't the level that they said for that, but some of that's funded. There is some of those additional contracts that we've picked up during the year, like He Pukinga Kaiawhina, that is increased in there as well. So you can see that above that line there about the other providers and the additional often funded or unfunded, depending on that make up that total there.
Okay.
So you can, if you wanted to, you can go up the top there. Regional AOD services, $681,000 wouldn't have been budgeted. He Pukinga Kaiawhina 245, and there's the money for the measles campaign, $187,000.
Just so I'm clear, are you saying, Jim, though, that these are ones that these are incomes that weren't budgeted for?
That's right.
Revenue lines.
And that's
Revenue lines that are additional revenue. So you've got the additional revenue coming at the top of $11 million at the top there.
So
And then it's got to go out the bottom somewhere. And that's where a lot of those things are going out other providers.
A lot of it's net, so you have revenue coming in and expenditure going out.
Yeah, I don't know.
Yeah, it's just
Except that for something like COVID costs, there's
No.
yeah.
And they never go out. They're out and out and out.
Just the other thing I thought would be useful to have another discussion on is the assessment of the risks going towards year end. Table 10.
Yep. So just going through those there, we've got the usual risk level there, or the risk level there around IDFs and what they may turn out to be. We won't know that finally and officially until about September of this year. We've got the risk there around the pharmaceutical costs and We're not sure yet. At the moment, there is some real data and then some estimated data to year end. So we're using those farming estimates to year end at the moment. There is the money that we put aside for the equity investment fund, which we won't spend all of it in this financial year, but we've got commitments around that. There is a little bit of a positive upslide. We tend to see that we make that non-specific accrual every month, but we do tend to see that we probably overshoot that a little bit. So we're expecting a little bit of a positive upside on that. Then there's the IBT wash up for in between travel wash up for 2 years in there. That there may be a little bit of upside in that. And the next one is the school dental.
So is that
school GP service.
Is that telling us that across these things, we'll have either $100,000 more revenue through to $170,000 more costs somewhere in there?
Somewhere, yeah. So pretty minor, yeah. But swing between the two levels.
Why it work, does it? Because the probabilities are all different. So is it saying that we're 75% likely to see increased IDF costs between 1.3 and 1.5 million? Is that right, or am I?
Yep.
And we're only 25% likely to see some improvement in underspend use pharmaceuticals. So is that right?
Yeah, that's what that is saying.
That's what they're saying.
Yeah. So you're right. It may be more on the upside or the downside.
I don't think you can total it, given you've got probability of very high on one and probability of quite low on the other. So it doesn't quite total.
But we can probably update those probabilities.
Yeah.
Because we're much closer to the year end to know what they look like. I think the equity investment fund, we could give that 100% now.
Right.
What exactly going to be?
Yeah.
I think that would be useful.
So the lines are more useful than the total in practice.
Couple of smaller amounts. I know we're talking big figures when we're talking that sort of thing, but going back to page 35, infrastructure costs and the adverse nature of that. I'm just wondering, we seem to always be, I know you're saying what it says here is general accrual, invoice timing, etc., but it seems every month we are out by amounts around patient meals, laundry services, etc. How do we reconcile that effectively? Because if they're out every month by a similar amount, then we need to shift our timing for the invoicing or something along those lines. But it strikes me as interesting that we, for something as simple as patient meals, that we're consistently out.
My comment to that would be the budget makeup would be less than what was expected. So it would be actuals against budget. So if budget's wrong, then we'll be internal review reporting against that budget figure.
Okay.
And it has increased. Price not. There's been no significant increase in pricing.
So we've just got more people going through the hospital or through the system.
Yeah, we're doing that additional elective surgery.
Yeah, sure. Okay.
Yeah. Which we wouldn't have budgeted for, but we've
close
on to $1 million to do the lot. So you're seeing that also in things like patient consumables. So we've put an awful lot more joints in people this year. So they're costing by that additional revenue, but you'll see a negative variance in the expenditure because of it.
Something I guess that needs to be covered for our next lot of budgeting. We're doing an next lot of budgeting, I'm not sure, but
Outsourced maintenance, we're spending a packet on outsourced maintenance, keeping this place running.
Sure. Yeah.
I think the other thing in this too is that we are operating off a set. We get a set of prices for services that we fund. So we've got an internal service level agreement that is built around a set of national prices, the national average prices that we utilise for that. But actually, the reality is that those prices are higher than what we can afford to pay. At the moment, there's a gap of about $4 million in the amount of work that the provider has done compared to the schedule of work that it was supposed to be doing and the cost of that. And that is in part related to the additional revenue. So around about not quite $1 million of that is funded. The other 3 million is not, and that relates to the national prices. And that is about to change again, because as part of this year's process around establishing national prices, they've gone up considerably. And so we are about to put together a internal service level agreement between the funder and the provider that will be utilising those new prices, and we won't be able to pay them. So we will have to be looking at how we're going to modify the volumes and the adjusters within that to cope with that. It's not the normal kind of business.
No, okay. And one other small thing that just jumped out at me when I was reading through these the other day was off-site accommodation furniture for $28,000. What's that?
Probably the
What is that?
Offsite accommodation fit. So
So
that would be
page
Hill Street?
so the amount of properties that we're leasing off-site. So we refurbished or furnished 3 off-site accommodation.
Corfu. The Seabeck.
Hmm.
Corfu House.
Just check which ones that is, but I mean, there's a number of areas that we will be buying those sorts of things, but yeah.
It's not accommodation to live in, it's accommodation to work in.
Some of it might be, because some of that may be where we are housing, temporary accommodation of people coming to here to work.
Okay.
So that may be where needs a washing machine or something like that. We have to provide one.
Yeah. If we're leasing a 3-bedroom house apartment that's unfurnished, we have to go and buy the beds, the couches, the cups and plates and linen.
So
that is a considerable additional cost for us at present.
Yeah, I was going to say that's
a situation of the lack of accommodation in Tairāwhiti to enable us to be able to recruit people and get them working.
Temporary accommodation. So how long would someone who's being recruited into the region typically spend in temporary accommodation?
3 months is a typical, but if we've got people here on a contract, say for 6 months, we would provide it for 6.
Are we noticing that it's getting harder for them to find?
Absolutely, and it is we have had people turn down jobs because they can't get accommodation. And also the cost of that accommodation is increasing, and we're affected by that as well. We've got a lot of long-term agreements with accommodation providers, and I'd say on the whole they're good in terms of and being responsive to our needs. I mean, we're good, effectively we're the tenants, so we're tenants in relationship to that, but the pressure is definitely on.
Do we use options around things like long-term, like a 3-month Airbnb?
I'm not sure if we've actually.
No, we've looked at it in the past, but I think it'd be more costly. So we typically use apartments in town, 2-bedroom, 3-bedroom. Previously, we'd pay sort of $500 a week for those, but during the recent activity and rent increases, have we got a place for you? People offering their homes for accommodation for $700-900 a week.
Yeah.
The other alternative is that we put people into hotel accommodation.
So I'm guessing some of this furniture gets recycled at the end of the 3 and 6 month contracts, because you're not going to buy a new washing machine every time around.
No, but it probably stays there because
exactly.
There'll be somebody else coming.
My point being that it wouldn't come with every new contract.
This is something new that we've done just because of the shortage of accommodation. Normally we buy furnished or we rent finished accommodation.
Sure. Okay. Thank you.
Just the demand is just.
Greg, where is the figure and the numbers for the total leave liability?
15. I think it's page 39
on the balance sheet. So.
Balance sheet 15.1 employee entitlements, which will be that'll be the whole gamut of all the entitlements.
So I couldn't put out the figure just for leave.
Of that, annual leave is 9.497 million. At the end of June 2020, it was 8.6.
So those entitlements represent overall 38% of our entire balance sheet liability against a total asset base of 86 mil.
So we really do need to start managing that.
Any other questions on the financial report? Okay. Thank you very much. We will note that in, I know, we're kind of at the really pointy end of the year now, but next month we'll get to the end of May. All right, board subcommittee reports. So we've got nothing, no public decisions to report back. Is there anything you want to raise from Hiwi today?
There's nothing came up.
Heather from FRAC?
No, in committees.
Okay, good. We've got an update paper on the establishment of the Consumer Council, which seems to be basically saying we'll get there in June. Noted. Nah.
Hello, kia ora. I just wanted to just revisit some of the stuff because we agreed to this in February and then the announcements came out after for the new reforms, and I'm just wondering where this now fits in the new structure.
Oh, well, to my mind, it continues to be critical. It's an important part of clinical governance, having a consumer council, and I would expect there will continue to be a consumer council after this DHB is basically a campus of Health New Zealand.
Mm-hmm.
Yeah, I don't see that changing.
Mm-hmm.
And it's, it's important to have patient voice.
Yes, most definitely. Wanted to ask where's the Māori and the makeup of it as well, iwi particularly.
So
I don't know who's that, but
So there's a.
because in terms of reference, still to be developed.
There's a document that was a PowerPoint presentation was done by Georgina at the time. They had a mix of what the groups were. I think what she's done, she's put about 12 members and she's divided that this will represent Maori. This will be locality of so a particular area that they'll be representing. So she did quite a bit of work around that piece. What is currently happening is there'll be an article. She'll be doing a presentation probably once we get a group of council members responding to the advertisement, and then we'll see. She'll do the selection process. But hopefully, we might find that there may be one individual who might meet 2 or 3 of those, or fill in three of those boxes, and that might represent the group. So, but we are trying to ensure that there's a reasonable representation.
And that item 2 under next steps, finalised terms of reference. What's the process for doing that? Will that come to here?
So what the plan is that we elect so she's drafted, so I met with Georgina yesterday, and she's created a draft terms of reference, which is based upon what the consumer councils are within the other DHBs. She's also created a job description for the person, the remuneration structure for it. The intent is that she'll do a profile on Wednesday, and then the advertisement will go on Facebook and a number of sites, hopefully by the end of this week or early next week. The limiting factor has been the availability of our comms team to get all these messages out and try and spread the message out that we are looking for.
So will those persons to be appointed in our June board meeting, if that's the timeline?
So it's end of June. Yeah. So the date has been pushed from 4th June to probably 11th June, just given the time, the availability of Georgina to help with setting up. I would expect what my goal has been to get it done by the end of June. So we have a set.
So
Those names
that we look at.
yeah. Back here, yeah. June.
We can update you at the next board meeting where we are.
Physical.
Just thinking of the structure.
Yeah.
Is it does it report to the CE? So it's a CE appointment, but.
Yeah, but you'll want to look at, you'll have an interest in, the board will have an interest in, yeah.
Is there an opportunity to do shoulder taper on this, or is it just straight from advertising?
That's what she's done. At the moment, she's gone through her networks and identified individuals who've either been in the post or have an interest and passion to drive that, and she's quite keen to ensure that she doesn't get individuals who've got personal interests and they represent more community interests and have more of a system view. So I think she's got the right. Just talking to her, I've met her about three or four times, and she certainly seems to be somebody who's quite passionate, energetic, and keen to get a really good consumer council in place.
I'd be quite interested in the terms of reference, the finalised terms of reference, particularly in relation to or Nukutai Meme and what sort of relationship that's going to develop into each state.
I can certainly circulate the draft terms of reference. What we found in this where I work in Auckland was that we created the terms of reference and presented it to the consumer board, and they then played around with it and said this fits in with our management type terms of reference, and we need to change it and how decisions are made. And so there was I suspect as part of that group forming, might relook at the terms of reference and make some changes, but we'll initially provide a draft, and I think I'll bring it back to the
So my suggestion would actually be that the draft terms of reference go through Hui, Te Rani and Te Waioro and Nukutai Meme in the June meeting, so that there's a process to catch any feedback before they're then in their penultimate draft to be tested with the actual Consumer Council and sort of finalised once it's been pushed and pulled with them.
We'll do that. Thank you.
Very good.
Now we've got a set of papers from our professional heads. Which are in some respects addressing some of the leadership issues that we've been talking about a bit over the recent couple of months. Now, do you want to grab a cup of coffee now while it's hot and then bring the coffee back and carry on? It will be just a couple of minutes, Josh and people. Nikki, are you able to mute the live feed just while we grab coffee? And we'll be back very shortly. All right. And now we'll pass over to you for our first item on the clinical leadership program of work.
Thank you, Kim. Yeah, so this is from a month ago, so it's a bit dated, but it just gives you a general direction of where we are heading. There has been some work started on that, predominantly around ensuring that we've got the recruitment issues are addressed. So we're doing some work around that, but the key bits around it is areas we're trying to target ensuring we've got the workforce that we need in the organization. So that's where that recruitment a bit comes in. And the second thing is around the leadership structures, making sure there's a channel of communication from the people on the floor to different levels. So setting up a head of department space and then a senior leadership team base. We've got both the general managers, the nursing leaders and the allied health team working together in terms of decision making. And then from that, that information flows on to the executive level team structure, and then hopefully decisions from there will then flow onto the board or to the FRAC committee. The second bit is around the clinical governance structures. As you well, for those who attended the FRAC meeting, there's a number of issues in terms of ensuring that the hospital is safe. So things, metrics like ensuring dataxes are actioned, and there's a closing of the loop for complaints. The risk management structures are updated and reflect current risks. So there is quite a bit of work in that. So the plan is to set a clinical safety group, council with clinicians and that are not heads of departments but represent various parts of the workforce. That group will then assess when complaints come through the system, dataxes, which are the incidents come through the system, and then they can assess, make institute committees or institute reviews of services when required. Once that's done, information from that will flow onto what is going to be a new clinical board, which will have a structure similar to our current board over here, but it's predominantly a governance structure that can then listen to key elements of things where decisions need to be made, and then that will then flow into the FRAC committee, and the FRAC committee can then pass on recommendations on to the board, where it's seen that there are risks for the hospital or there are areas that we need to target on. So it's to ensure that we've got a safety net system in place and that there's several layers of it, and that information flows through depending upon the level of risk to various levels of the system. So at the moment, we've got that work being organized by CARS. We've done the terms of reference for the clinical board. We've done, we're looking at setting up the membership. The Clinical Safety Council is still work in progress. We need to do quite a lot of work. Currently, the quality department is a very small department consisting of one quality coordinator and one support person, and is an admin person. So normally for a hospital of this size, it will require a bit more of that. So we will need to put in a case through the appropriate channels to recruit some people who can work as quality coordinators for services like general medicine, general surgery, and mental health. We do have a reasonably strong quality and safety system in maternal and pediatrics, but for the other service areas, there's a lack of someone responsible for that. So there will be some, as we build those structures, there might be some resource implications, but it is important for both ensuring that the hospital is safe, but also giving you the reassurance as a board that we've got systems in place to manage risks and ensure it's a safe hospital.
What we might do is we can carve out the clinical governance paper and then sort of have questions on them as a job lot.
Okay.
Yes.
Got it. Thank you. So as per Anil's introduction, there's quite a bit going on, but clinical governance for lots of reasons is the thing that kind of underpins a heck of a lot of the work that we need to be doing. We have combined our efforts with regards to what we think is the most important to get done. So I've provided an information paper just about generally the reasons why. In those next steps, establishing the clinical board is very important. We've got our terms of reference. We are working on making sure that that also gets communicated. So we've got clinical governance in place currently, and it doesn't mean that everything. We want to keep the good and then embellish that. And I think the board is one way of doing that. The information, the presentation that I've also attached in your pack was a presentation that I did to people that were attending our clinical governance committee. So in essence, what I'm asking for is partnership here. We're not wanting to reinvent the wheel. It's really us as clinical and professional leads saying, how do we do this better? The board being a part of that, the clinical board, I mean, being a part of that, but there's also a lot of work that needs to come underneath that and feed into that. So Neil touched on where our leadership actually feeds into clinical governance. It's really important that we've got structures and that our leaders are regularly meeting and able to do some of this work before it comes to a board level. We want to be sure that the board can make those decisions, that they are well worked up and that the right people have had, lent their thinking to what we need to be doing. So in essence, if we keep doing what we've always done, we're going to get more of what we've got, and we just can't have that. And for us to be effective, some key principles of clinical governance need to be adhered to. And that, and at the kind of macro level, that's about clinical effectiveness and research, audit, risk management, education and training, patient and public involvement, information and IT systems, and then staff management. So all of those pillars need to be incorporated. But what we've, as a professional group, as well as working with our lead for quality, the things that we're really keen on is assurance. And assurance is probably the thing that has been the predominance of what we've done in our clinical governance space. So it's not that we want to discard that, we want to embellish it and actually make it more relevant. Representation, so we do need a consumer council, and I think we had it kind of mentioned before that we don't know what the new world will look like, but consumer representation and clinical voice, that's in my opinion what we have to get in order to get our house in order in Tairāwhiti. Workforce, having the ability to have a fit for purpose workforce, people that are educated about what the mandatory training, what the education that they need, and also make sure that their cultural safety matches their clinical safety. That's a really important component. And then clinical excellence. So ensuring that we've got the innovation that we want to drive from the floor, that's really well captured, it's well thought out, it is tied into overarching research strategy, and that we've got some eyes about what the projects are, making sure that those are rapid tests of change rather than these kind of extraordinary pieces of work that tend to linger that we don't learn from. All right.
Great. I'll just make a comment and I'll throw it open. So I just wanted to thank the three of you, Carl, Nell, and also our Director of Midwifery, Jim, for this work. This is, to my mind, this is really important stuff. It's addressing, laying out a program to address some of the issues we've been talking about in recent months. But actually also, what you just spoke of about having a disciplined process for bringing the clinical voice and the consumer voice into the decision making around this table is and into the discussions at the executive management level. It's just, that's, I think, will get us to a point where will help us to leave our job here next June in as good a place as possible. So I did just want to thank you for the work and the effort you're putting into this, and particularly, I know two of you are very new to role. So, it's great to have the new, fresh, all of you working together and building this body of work. So Whenā tāku, nei, it's
Kia ora. Thank you for the presentation. A couple of questions, if I may. I'm just looking at the 7 pillars of governance, of clinical governance, and my question really is, how do you see cultural leadership playing a role in these, because they aren't in the presentation. And yet, in the annual plan we're about to sign off, the first line is about equity. The second line is about Māori leadership. How does that feature in these 2 proposals? And I'm talking about Māori clinical leadership, just to be clear.
My take on that is making sure that as part of the board structure, the clinical board, that we've got that voice representing there. So that would be within our, I guess, our terms of reference for the clinical board. With regards to the Māori clinical leadership, that needs to come at all levels. And I think especially when we are doing the pre-work, as in before it gets to that board space, having our Māori leaders actually involved in that decision making. So some of that would be, I can speak more eloquently on behalf of Allied and Technical Directorate. So that is where we've got a local engagement forum where our leads are making the decisions that matter, closer to the floor to them, and things that are then not being able to be resolved amongst ourselves then gets escalated into that clinical board perspective.
So in the clinical board is really, I'm saying both spaces.
Yes.
The clinical board itself, under the terms of reference, specifying cultural leadership in that space.
Right.
Just asking.
Yeah.
And actually, arguably for a region where half of our population
50%,
and where our political drivers are really around equity and treaty, maybe it is a pillar of good clinical governance for us, in addition to these 7.
Yeah.
Look, I think it's a valid point. In fact, we spent about an hour talking about that just prior to the board meeting. Look, I totally agree with you. 50% of our population are Maori, and so it's only 25,000 people. We should be delivering a fantastic care. And one part of it, to drive that, we need our clinicians to think in a different way and to deliver that care. Our workforce, as you know, 90% of it are not New Zealand trained and that come from overseas, and hence there's a bit of a cultural gap there. We can do a whole lot of cultural training and things, but in terms of the actual changing how they deliver care in a whānau-centered way and things, that's going to be quite a lot of challenges. So we need to build some leadership structures, provide some leadership for those people to actually deliver that. We have a very strong nursing and allied health workforce that have a strong Maori voice. It's maybe probably linking the 2 together to ensure that when a patient comes in, there's that context is taken into account where you're just not providing a very westernized way of providing care. And our numbers, like our stroke, for instance, very few, we're one of 2 DHBs where a number of patients with stroke don't go off for clot retrieval. And there's been, say, 30 patients who've had strokes within the last 3 months, of which only 2 have had thrombolysis. There's no one's gone for clot retrieval. That's quite different from a different DHB, which has also higher Maori population, Northland, so they have a higher proportion of that. So we need to do some work educating and making sure that our systems are set up to deliver really good care for the patients that come through our doors or that are in the community. It's a key focus of what we need to do, and I'm hoping that the Consumer Council will aid in that piece of work.
Yeah, so just to be clear, and no disrespect to anyone else, but I'm talking about a treaty relationship. So the cultural aspect I'm talking about is Māori in this space.
Yeah.
Linking up both with the population base here and the treaty relationships that were spoken about earlier. So how does that infiltrate or balance out at every level of the organisation, especially as we're developing new processes? It seems this is a really good time too.
It's a bit hard, don't you think, it's a little bit hard to really know how to give direction and support to our clinicians, we ourselves are trying to understand exactly what that means, as opposed to quickly going into a situation where we start requiring particular things when we actually haven't had the conversation and, with leading things with iwi. Because a treaty relationship is a place-based relationship. Do you understand what I'm saying? I'm just unsure because I think the priority is getting the clinical leadership governance issue addressed. Don't get me wrong. I think it's really important, but I also think requiring an immediate conversation as well, which has got to be a little bit careful, because I think that requires some direction.
My own sense is the clinical governance board isn't a treaty partner, say.
Yeah, exactly.
It's
It's
a creature of this organisation.
Yeah.
I don't disagree with that either. All I'm saying is from this level here, we should be looking at those in every aspect of our business. And that's simply one aspect of our business. So is the Consumer Council, so is blah, blah, blah.
Yeah. And the answer to that is we are.
Do we have
It's not in the papers, is why I'm raising it. It hasn't come through. There's nothing in there. It's void. So that's the reason why it's important.
Do we have any idea of the size of the clinical workforce who will identify themselves as being able to fit the profile of working in a Māori way? Because that would probably be the first step that the clinical leads would need to do, because many people who are Māori don't feel confident that they would be able to provide that equal balance between clinical and Māori. If that's what we're asking for, I think it would be really useful to see.
Isn't it about reassuring those people and supporting them to activate in that space? Isn't that the real crux of this?
Making them feel
You can't
safe.
just drop one person and expect them to fix everything.
No.
Absolutely not. But building those supports around them is the important key.
I guess that was the point before about it needs to be throughout the organisation, and that has, that's not in a tokenistic way. That's in what our leadership and who our leaders are. And I can once again speak for myself that Allied is fortunate in that we do have Māori leaders in leadership positions and in designated positions that we can be drawing on. But absolutely understand your point that it does not mention that in these papers. As part of the terms of reference and as part of the clinical board's makeup, absolutely that needs to be addressed. One issue I'd just like to, just a comment to that, would be where Te Kauri Pakiku fit in this, because in my perspective, from my conversations, I was invited to spend some time with that kahui, and the clinical and the cultural need to be hand in hand when it comes to that. But formalising what that looks like and kind of where that all pins together, I think would be quite helpful.
The other part of it too, if I might just say around innovation, it need not necessarily be staff on site. We do locums every day here. We spend money on people coming in every day. Just throwing that out there as well. Just saying.
I think just in terms of progressing this, and it's that stage where the clinical board is being formed, it might be a really good time in the spirit of partnership to work with you and see how the constitution will work. What I can do is Carl and myself can meet with you and Professor just in terms of trying to see how that structure is and it achieves what the purpose of. Because as the board, we are reliant on your advice in terms of trying to tell us how you think the structure should be. I know it's purely, the focus is currently on ensuring the hospital is safe and what we're providing is safe, but we could also ensure that this is incorporated into that.
I think we're inviting you to the next Te Waiora Nukuta Meme, aren't we? Maybe we could have a part of this.
The professional leads.
Yeah.
Will
do. Thank you so much.
And now has an analysis been done between the fatigue and burnout and leave liability? Just wondering. Maybe there's some issues around people not being able to take leave, or other people who have got fatigue and burnout are the ones that are taking their leave. Has there been anything?
I haven't. What I've seen is the last study that was done by ASIMS, which looked at fatigue and burnout. And it broke it down by DHB, and obviously we're one of those DHBs that has a high rate of that. But in terms of relationship to leave, I'm not sure. So there's a lot of components that constitute burnout. One is patient-related and staff personal related, and then the hospital related stuff. So we just have to break it down and try and understand it a bit more. It is very difficult to tackle burnout, and it's not an easy solution to it, and leave is probably a factor into it. But yeah, it is a difficult one, but I can certainly look into.
Yep. And Carl, your clinical leadership, and I always go on about this, is it going to include clinical non-DHB as in primary care, maybe aged care? Because they do work hand in hand. What happens here affects out there and vice versa. And I know that's kind of fallen off in the last few years.
Noted.
Thank you.
Yeah, page 48 on your report, Kyle, just the sentence before next steps. I just wondered if you could just talk me through why clear decision-making is currently missing.
That comment relates to the Clinical Governance Committee and the way that has been functioning in the months leading up to this paper kind of being worked on. It was comments from the discussions about people attending clinical governance. It was related to frustrations, people feeling that they've raised this issue and no decision was made, and it wasn't actually communicated what that decision was. So part of that sentence is really about, for us to have effective clinical governance, we have to have very clear ability to make a decision, and then for that decision to be, actually put into action.
So the structural way in which decisions are made?
Yes.
Okay, yep. I get it. Thank you.
I think it's important to recognise that we've always had a clinical governance committee of some form. We used to have a clinical board. Yeah. We went through a review process. We changed it to a clinical governance committee. Now we've gone through another review process and we've changed it back to a clinical board. There's different dimensions around that. So it's taken, as Carl was saying, taking the positives out of what we had and then, adding more to it. Yep.
And nationally, there's no consistent approach. So there is no one way to do it. And I think that's really important to note. We have to find something that works for us and actually in our space actually works across the board, including into all of the parts of the system.
I just want to talk about what Nga said and also what you said, Madam Chair. I'm really excited to see this piece of work. And I just note that this kicked off in April, and so we're almost at some of the benchmarks on the Gantt chart there. So looking forward to updated, detailed updated reports. But this is a really great response, and I just want to congratulate, from my perspective as a board member, the people that have achieved this to date. And yeah, really, really impressed.
And thanks for the paper, Carl. For me, part of it is about, if we look at the workforce, the onboarding, the mandatory training, the clinical leaders are the ones, I believe, who need to have mandatory training in the Treaty or Waitangi partnership, exactly what Nga was saying, because they're the ones who have the biggest influence, on culture of clinical safety. And if we're talking about mandatory training, it would be good to see that level of clinical leadership, taking part in that.
Thank you. We also, just from a leadership and management perspective, that has, just to pick up on your point, doing that well, actually empowering people that are in the leadership positions to be the leaders that we need them to be, including holding the line when it comes to cultural safety, when it comes to improvements, a culture of improvement and the way of actually getting us to where we'd like to be in the future, and making the training so that people coming new into this organisation actually have a chance to do this learning curve that we need them to do quickly and be work ready and safe to practice here. Yes, noted again.
Also a concerted effort around getting Māori into leadership roles and making those pathways accessible, so we have got no barriers, and that at every step along the way it's achievable. So that's where we're starting as well.
Look, well, Kapai, thank you. I think we'll wrap this conversation up. But suffice to say, you clearly have the support and thanks of the board for the work, and also actually for the time that you all spend coming to the meetings. It's well, certainly for me, I really appreciate having the professional leads here at the meetings advising us. So thank you. Now, Sarita, we'll pass to you on the care capacity demand management paper, and just a heads up that the real question that I've got burning is, what's our pathway to full implementation?
Yeah. So I'll take the paper as read. This is a requirement from our CCDM council to report up to the board. So there's this idea, it's floor to the board. So this is the board part. It's a very technical paper because it's based a lot around operations and around the operational components of getting CCDM where it needs to be. But the take home points from this is that we need to get the implementation by June of this year. The things that are holding us in a bit of a holding pattern, because we are at 56%. Now, 56% may seem like, oh man, we've got a long way to go. But the two components that when we achieve them will just get us up quite fast. And so those components are the IT, within the IT space. So we're looking at the core data set visualization tool. So that allows quality measures to be viewed by every member in the organisation, and you can get down to detail. So the quality measures are things such as patient incidents, overtime that we might be doing, vacancies that we have, anything that would be impacting, and this is from nursing and midwifery in particular, but it is with allied as well. So when we get that, we will jump up in leaps and bounds, and we're staying optimistic that we have a 3-week window, we've been told by IT, that we can achieve this. Implementation, what that looks like. So our council has been working with Safe Staffing Unit and TAS to get that definition, because the goalpost keeps changing. And so they just keep sending us back all these tools. So at the moment, how it rests is we've got a tool or a spreadsheet that we mark ourselves against. And we seem to be faring well with those two mitigations that I said that I have mentioned. So we look like we could make it. And should we, I mean, this is based on one of the prime aspects from last time's negotiations in 2018. So I'm putting my bets that this is a big thing that they're talking about right at this moment. So it is quite crucial that we keep tracking on and making the progress. Does anyone have any?
No, very good.
Very good, no, thank you. I know this is when I first came across it, I had no idea what CC was. And I was looking at it from
its own language.
Yeah.
And they're well ahead. So,
but yeah, no, good. I know it's a big thing. You know, it's a significant body of work that's done. So
yeah. One of the things around the body of work, which if I can, so you talked about leave liability management. The lingo that they use in CCDM is your plan A. So if you get your plan A right, then your plan B will flow on. Your plan A is getting your base rostering all sussed. And if we can get that right with our FTE calculations, then we will be able to manage those leave liabilities. I mean, it would just be business as usual or just a on over. So we want to focus on that with our plan A.
One of the things I learned was the still learning how to use the HAG.
Yes, yeah.
And I just thought if people wanted to see what part of this is all about, for me, it's very visual.
I'll give it a whirl.
If you open it up and then maybe share it.
Which one are we doing? Sorry.
The hug screen. Go. Yeah.
It's good on the visual.
Get it up.
Yeah.
I know, just, sorry, if you just go back. Do you want me to do it? Yeah. It's ugly sun where Josh is. Can I get out of it?
The sun did come out for 10 seconds.
Yeah. Why?
It did. What was that?
Okay, if you want to share that.
Yep, I have to open the shares in first to do that.
Oh, yeah.
So I'll just do that.
Do you want to keep talking because it'll come back shortly?
Yeah, so I mean, I was just going to say if that wasn't available, if you wanted to show board members who wanted to have a look at it.
Oh, yeah.
The screens.
Yeah, it's a good idea. We'll just pop it up on the.
Yeah.
Okay.
But do you want to? Yeah. Is there anything? Yeah. Carry on with anything else about CCDM?
Just on.
Do you want to just talk about allied health CCDM as well?
More than happy to. So care capacity demand wasn't as explicitly outlined in the PSA agreement as it was in the nursing accord. So from an implementation perspective, allied is 18% implemented at Hauora Tairāwhiti, so that is a significant lag. With regards to what's happening nationally is that we also have support from TAS and the Safe Staffing Unit, but that support is very limited. So there's a 1.2 FTE associated with all of allied health implementation for CCDM in New Zealand.
Wow.
So that just shows the commitment that's out there currently. And a lot of the stuff that we've been doing here has been kind of on the goodwill of nursing. So we've had our coordinator, Karen, has been fantastic. She helps me out a heck of a lot, but we're actually not visible. We've got little screens there on the HAG screen about what our capacity is, but that's not fully live just yet. You want to take them too? Or?
Sure. So what you can see here is literally what it's meant to be, a hospital at a glance. So you can see by each pillar represents a ward, and you can see the shadowed out parts is the capacity, the bed capacity of what that ward can accommodate. Then up the top a wee bit, you've got the index of what each population represents. So that purple and the on the right hand side there would be orthopedic patients. So you know where they are, and the screen refreshes here. So the screen refreshes every 3 minutes. The part that we're that I mentioned in the paper that we're working on is along the right hand side with the empty boxes there. So you've got theatre, district nurses, and then down below where we've got there, you've got the clear boxes, is a traffic light system. Okay. So your staff on the wards will be able to look at a criteria and mark off, did we all get our breaks today? Do we have the full complement of staff that we need? And that will trigger a traffic light response so that we know in any given time, if I'm in my office, I can say, oh my gosh, ED's in red. I need to go down and see what's going on there. So that's the point of the the VIS, so variance indicator. And then the numbers below that, this is where it gets quite technical, is the variance. So day ward at the moment, which is DW right in the middle, that it's just 2 blue squares. They've got a variance of 14. So it means that their hours are positive 14. They've got capacity to take on patients, but we know that their flow is continuous. So they've probably got more oncology patients coming through and yet to sit in their chairs. On the other hand, you've got Ward 5, the W5 there with the big blue. And the crosses, I believe, might be
people discharged.
So that's how we can anticipate we've got quite a few discharges happening today.
So that's the planned discharges for today.
Yes.
But they're still actually sitting.
They're in the beds though.
It's still there, they haven't gone.
But it
refreshes every 3 minutes. So as the day goes by, you'll see those crosses being removed as people leave the ward.
Right.
So what does the E stand for?
elective.
Yeah. And then
The little
diamonds, I'm anticipating admits.
Booked to
Yeah.
come in. Yep.
Who are the P and D with the minus? What's that group? Can you go up the top?
Third from the left.
Third from left.
This
Postnatal.
Is that? Oh, okay.
Yeah.
So that means they're short-staffed. The minus?
No.
Because that may not be, there's a variant, there's a tolerance level built within CCDM of 8.5% of nursing hours per patient day before you get to what is called a shift below target.
Yeah, quite a methodology to running this program.
Does it require a lot of user input?
Yes.
It does.
Yeah.
Is that like clinical
Based on the
training?
patient.
People to be allocated
Yeah.
what type patient type they are and to be so they get allocated when they first arrive, and then it needs to be reviewed by somebody, and that's called validated. The patient type and thing. So yeah, at the moment it's saying there's nobody in the delivery unit. There's 3 babies in the neonatal unit. There's 8 in the postnatal, so that will be inclusive of mums and babies. There's 6 in the pediatrics, which 2 are the electives, which will be day cases. There is 21 currently, 22 in the medical ward out of a total number of 24 beds there. The greyed out person is somebody that is there yet but hasn't been allocated a patient type. And then as it shows there's that number of people that will be leaving the ward today, and those areas are all quite substantially positive variances. This is our combined orthopaedic and surgical ward. It's just refreshed again.
Wow.
Just move me down the page.
That's me.
So there's 30 odd beds there. It's inclusive of the ward plus the annex. There is 21 patients in there. At the moment, quite a chunk of orthopaedic and the rest general surgery. In day ward, as we've just talked about, and 1 more to come in. In day of surgery unit, there's obviously those all elective and 1 more person to come in there. In ward 8, which is our combined frail elderly rehab and 1 other ward. Only 10 people in there at the moment, 2 more to come in, and a couple of people that have been put from here across here for their elective cases today in the intensive care unit, which is nominally a 6-bedded area, and there's 4 people in there at the moment. Currently at the moment, only 5 people in the emergency department, of which 1 person has waited more than 3 hours in the emergency department. Mental health unit is again, there's a nominal number of resource beds in there of 8, and it's full of people in there. It's not full. Yeah, these are resource beds. So they're not physical beds, they're resource beds. Yeah, so it's an important distinction. Dialysis, got all our chairs used today.
Can you describe the difference?
Start that again on the resource bed, sorry.
Yeah, give us a clarity. It's a little bit like the number of beds you've got in your house. Okay, so I don't know how many beds you've got in your house.
Yeah.
But you don't buy groceries and have the capacity to use all those beds on a day-to-day basis. So you think, at the moment there's 2 or 3 or 4 people here, so I buy food for that many people, and that's what we staff it for. But if you had people coming to stay for the weekend, you would have 2 extra beds in use, and you'd have the extra resources to put into place for extra beds. So this is what we set. These are our resource beds. This is what we set the organisation at. And we try to run that at least 80% occupancy at all times. That's our sort of target. And the staffing level is built around, as Sarita was saying, we've just done FTE calculations. So we've worked out what is the average demand by day of week and by shift, and we've built the staffing calculations around that. So we know that we have to resource approximately this many patients with this many hours per patient day. So it's a little bit more sophisticated than just beds. So it's about the resources that this mix of people will need on a shift by shift basis on average every week of the year. And that's how the staffing is based. But and so we're resourcing those beds to do that. So I'm not sure if that's really explaining.
What's the difference between Ward 5 having 21 patients in the grey bit and the capacity to have 24 beds?
Yeah.
And the mental health one, which has got 8, and it looks like, from my calculation of what you were doing over here, all occupied.
Yeah. So it's just
Is that correct?
So what I'm saying here is that
So it's full.
that we on a day-to-day basis, we resource 24 beds in this ward here,
Yeah.
in that ward there, and we, on a day-to-day basis, we resource eight in that ward there.
And it looks like all of those beds are occupied.
Yeah.
But that's
it
not to say
doesn't-
there couldn't be
It doesn't
more.
say we
No,
couldn't
it'll be
have
down
more.
there.
So at times you will see that go above
Yeah.
there.
Yeah.
And at times there will be more staff, and so that's where this number comes.
Yeah.
important, that you're actually matching the demand, and it's also not about,
Yeah.
it's not patient ratios,
Yeah.
it's much more sophisticated than
Yeah.
that.
So
It's the type of people.
Acuity.
Yeah,
So that
the
eight
trend here is what
beds,
we use.
there could actually be 10 or 12 beds in that.
Yes.
There are eight. There are
We can
eight
accommodate.
futures.
Yeah.
But there may be more used at any time.
Yeah.
So there's more beds in that
Yes,
particular.
yes,
Ah,
yes.
got it.
So you're not buying groceries
Areas,
every day.
There's more people that we can get in there, but once you get to, when you're looking, it's a dynamic process, so all the time you're looking at your
So
hours per patient day required, and for that group of patients that are here now. So that's where variance response management comes in. So you actually set this up, you do your calculations, you look at the data over a 12-month period, and you say on a Monday morning in Ward 9, we need this many staff, because this is what it looks like on average on those days every day of the year for 12 months. And so you set that staffing level, and all of the associated, that many people needs this much annual leave, they need this much study leave, they need this much sick leave, they need this many people.
But there's ability to use dynamic staffing if they
That's right.
haven't got
Yeah.
enough staff in one place, you can transfer them.
Yes. So
Across
it's not showing up very well yesterday, but
Capacity
Yeah.
demand management.
yeah, they've got basically, very crude terms, they've got two nurses there that in very crude terms, you could say, if suddenly there was a problem somewhere else, that we were short, we could shift one or two nurses out of there over to there, and that's what we do. That's
So,
what
Jim,
response management.
what does it mean when we're only 56% of the way through with this? What does that mean?
Oh,
That's for the overall program. Oh, the program related to it. Oh.
Yeah. Once that's been sorted, we're going to zip along.
Okay,
Does it show up if anyone needs specialing or anything like that? Is there a little thing in
That's
that?
in addition to the acuity of the patient and the type of patient you put in.
Okay.
so okay.
it's not.
Thank you. So that's been really useful, but I'm going to move us on. I would like to play with quite some time.
Yeah.
So thank you, that has been, it has been really illuminating. And good science is sitting behind getting to plan A, so it's great.
And I know the 4 o'clock Tuesday morning, we'll look at it.
Come in.
This Tuesday morning would be good, if you had to do it.
Thank you to all of you for those papers. We'll move on now. We do have a vaccination update paper at page 58. It's there if anyone's got questions. I had just a couple of things that I thought would be useful to do. One is to talk through how people know they are in the tier to be vaccinated and go about getting vaccinated. So if we could just talk about that. And also how we're going with vaccinator recruitment and how many of our total trained pool are actually active. So, what's our capacity to wind up from our current trained pool? So those are my sort of current questions around.
Okay, so currently we have around 30 vaccinators, of which around 20 are active. That's across our services, including our Māori provider network.
And ARC.
And ARC. That's one question. The authorisation is moving.
And there's
a lot
more being
quickly.
recruited.
So we've got 30.
Yep.
That's where we were at last month. So how's the recruitment going?
There's another 10 in the pipeline.
Yeah, we've got an open recruitment process underway, and we have undertaken the interviews. Orientation started on Monday for that group of people, and the process for authorisation is part of supporting that workforce to come on board.
So they will be upping our number of actives as we roll into next stage. Okay.
How do people know at this point in time, tier 2B, we did all of the ARC frontline staff with every other frontline staff member that was invited. And we would have completed the first, residential care vaccinations for event 1. So they were notified with their ARC services, and they've consented and done all the things that they needed to do through that process.
What's the uptake like in aged care?
Can't give you that information at the moment.
Very high.
It's quite, yeah. So my understanding is that every person who was offered a vaccine received a vaccine. Wanted a vaccine, not the vaccine.
So do we know in that total doses, how many are a second dose? Like how many?
Sorry?
So do we know in total doses, how many of
Not in
them are
detail.
second doses?
Not in detail. I did have it, it's in the documents, it's on somewhere that nominated how many were first and how many were second. I thought having a total.
So we report that through to the ministry and
Through the CIR, the COVID immunisation register.
Once you're vaccinated, your information is uploaded.
And Nicola, the people in tier 3 which started yesterday, so how do they know their process?
Not quite to tier 3 at this point.
Oh, our paper says it started on the
24th of May.
We are in tier 3.
Oh, sorry.
Yeah, sorry.
Sorry.
So we are in tier 3. We're back in
entering into. So we're entering into. We had hoped that we would be working alongside of older people, Māori, who are in the same like-for-like situation as residential care earlier. But advice from both of our Māori providers who are working with us is that they wanted to delay that. So we are currently working in Hauora and in fact, we started in Hauora today, and we're working out of the Tairāwhiti health offices for the next tranche of moving out into the Western rural environment. While we're sourcing fixed sites, we know that Puhi will deliver vaccinations from there. We're working through a process at the moment to invite participants to join us into that in that workforce. And that tier.
Yep. So my question was more to me as a member of tier 3. How do I know?
We're working through the process of we have the information. It's then how do we're working through the invitation process.
So I think it'd be really useful if we can get that that information available as quickly as possible and probably up on our website so that people who know we're on tier 3 know how to do it.
So the comms team have been working closely with the Ministry of Health team, and they were about to go live a little bit earlier than we were ready for them to go live. So our comms team, along with the rest of the country, I think, asked that the ministry just slow up a bit while we could organise our local information to go out. And so that's where we are at the moment with that piece of work.
So the CIR COVID research says we've done total 4,666 doses as of yesterday. So this is actually in the thing. So there'll be a few, well, not quite, because there'll be a few people that won't actually be in the CIR yet, as some of those doses will have occurred in the community. Of that, 2,841 have had their first dose. And out of the total of 464,666. So that's 1,825 fully vaccinated.
Very good.
My question, Nicola, is in relation to paragraph 4, the bullet points dealing with Tūranga Health, Ngāti Porou and the Pacifica communities. It was sort of, I mean, there are some timeframes indicated there, but it's a little bit loose from nailing those goals. When do you expect to have negotiated church sites for delivery to Pacifica? When do you expect the sort of whānau or kaumātua champions sort of, I mean, it says by end of May, but we're literally at the end of May now.
So the 90 vaccinations, this was written in predicting what would happen. The 90 plus vaccinations have been completed in Tairāwhiti Health.
Right.
We are a little bit of HR and getting our coordinator up in place. She came on board last Wednesday. She's getting orientated at speed. That's some of the work that needs to be caught up on now. There've been 2 prime people basically working the planning and the delivery and the support for vaccinators on the ground doing the work to date. We now have a coordinator in place that will pick up a lot of that work.
Is that enough capacity there, that right?
It hasn't been enough capacity to date. We are seeing a little bit of light with the employment of the coordinator and the comms person coming down the line and vaccinators coming on board.
So it's all coming together.
It is coming together. I don't want to get too optimistic just yet. Anything could happen, but it is feeling like we're seeing a little bit of light. We do know that the biggest population group are eagerly waiting. We are we don't want to provide information that may not be correct. So we're still looking at landing some places that are closer to the communities in need, such as Elgin and Kaiti. And there have been places of interest that we are still to negotiate with people who have those venues.
When we're rolling it out, are we looking, I don't know if it's possible or not, but are we looking to also promote flu vac or not?
No,
are we doing quite separate?
They have to be separate by nature of the vaccine.
Oh, yeah. Okay.
2 weeks. Yeah.
The other notes that you're seeing in there are around really gleaning any other support that we can add to our vaccination workforce, and there are some quite stringent expectations in terms of what any other vaccine standalone group can do. And we've provided people with information around that. We're preparing AOIs that explain very clearly what a pharmacy or general practice might need to have. We have indications that there's probably only 2, other than Ngāti Pro Hauora and Tūranga Health owned general practices. There's probably only 2 others that would be interested. We're still to understand where pharmacy needs to dip its toe in.
So it doesn't matter if you live in a community, you can go and get your COVID vaccine there, regardless of where your GP is.
Yeah. We're wanting to work with GPs closely with regard to how they want to be involved with the invites. But there are a number of ways that we think this could happen, using radio, using social media, using mail drops to inform our community of how they can go about doing those things. That resource still needs to be sorted. But it's underway, and the comms team have been working on it. We've had to provide quite detailed information to the ministry as early as Monday was the final dates that we had to get some of that information in. It's now turning that around to say, and this is what you can expect, community.
So I think you're probably getting a sense that that's what the board is looking for.
And yep, we really want to get you that information.
Right.
So there's a big push in the moment to get flu vaccination. So is the information clear that there should be that 2 weeks between? It's clear.
Yes, that's why the push is to get the flu vax going now, so that's gone and out of the way by the time the COVID vaccination comes in. The majority, the biggest push around COVID vaccination is not till July, from July onwards, for the wider community.
Okay, thank you, and we'll continue to receive these monthly updates and look forward to continuing to ask questions about them.
If it's helpful, we can provide to the board and committee the information that was sent to Ministry of Health next meeting. In terms of the detailed planning.
It'd be good to see
the detailed plan would be good.
The second dosage.
It's 1,718.
I mean, there's a lot of logistics that we have to take on board.
It's on the COVID website.
Okay, so just our last item, which I'll talk to actually, is the ransomware incident that occurred. So I asked for this to come onto the agenda on a couple of fronts, and we're just going to, this is just a verbal item for the purposes of this.
And Max is there if
kia ora, Max. Yep. I think we might push any questions a little bit later, but this was really to just get a sense more from Jim and Anil, the extent of impact on our transferring of patients to Waikato. And also, which we'll talk about a bit later, is the, well, no, we can talk about it now, it's just the assurance from Max about our systems and the level of protection we have from such an attack. Bearing in mind, of course, that the media have reported that it's likely that it was an opening of an email. And so, you know, I mean, that's it's a key thing to protect against. But anyway, so if Jim and Anil, if you can talk about the impact on the provision of tertiary services for us, and then Max, if there's anything you just want to underline about our level of protection from such an attack.
I mean, I'll start off, you add in. So we know, everybody knows it's been very disruptive to services at Waikato DHB, and not just at Waikato Hospital, but also the outlying hospitals as part of their network. And that has impacted quite a lot on our ability to utilise services at Waikato that we normally would do. The pathway right from the word go has been for our clinicians as usual to manage care here, and then where they do need that higher level of input or support around the patient, to make the same contact with the relevant clinical team at Waikato DHB, and then to have a discussion around, you know, what can be done there, or whether the person needs to be diverted elsewhere. Primarily that has been around people who've had heart attacks, and in the main those people have been going to Bay of Plenty DHB, but also I think to Wellington as well, if there is capacity issues and need to transfer it somewhere else. So that's sort of been the most major impact. The other area will be around planned care for Tairāwhiti people with planned care. And we know that Waikato DHB is now back up to around 80% of their normal planned care capacity. And remember, that is planned care. So that's not, that's a combination of people getting treatment and, you know, first specialist assessments and things like that as well. So that will be impacting Tairāwhiti people. And the third area of particular interest for us is around people requiring radiotherapy. Their radiotherapy service at Waikato has been out for this whole period of time, and so that has necessitated utilising capacity elsewhere. For us, that would be at Catherine Kilgour Centre in Tauranga, to be able to provide that more urgent radiotherapy requirements for people, particularly around those people needing palliation. So that's, I guess, where it is at from that point of view. Do you wanted to add anything?
No, I think you've summarised it well.
Great. So that's the first leg, is the assurance about services. And Max, is there anything you want to underline a particular importance around sort of assurance around our cyber protection?
Well, I guess the overarching comment is that we as an organization embrace the threats of the national security nature on the daily basis. We have protections and measures in place that allow us to operate in this very fast changing environment. And we as an organization need to make sure that the information assets that we operate and use to carry out the business have a set of measures in place. The particular incident that we're part of, or the nature of particular risk, it's nothing new for us. We have had in the past the occurrences where this particular type of threat or malware have exposed elements of the staff and has prompted responses as to how do we recover from this, recovery of the data, making sure that the business can as much as usual. And this is a very similar set of protocols that we have once again continue operating in the time where our colleagues and partners at Waikato and the organizations supporting through. We do remain on the high level and on the lookout for any specific cooperating and working with this, the Ministry of Health as director specifically digital, and the CSC, which is Computer Security Center, and cooperating with this GCSB, carrying out a set of investigations, including criminal investigations. We are following the guidance and relying on ourselves in the response to those principles and specific steps that we have taken. And yes, and like I said, in the meantime, the focus for us to be able to provide as much of the business as usual.
Fabulous, thank you, Max. So what I'm just going to do now is thank the members of the public who have joined us today. That brings to a conclusion our public session, and we hope to see you again at our next board meeting. And just put the motion that we now move into public excluded, and Nikki, if you can done it.
I'll just wait a minute till we.
This might be delayed.
Numbers change.